I am delighted to introduce Dr. William Resch tonight, who is a psychiatrist in Columbus, Ohio. He's affiliated with multiple hospitals, including Chillicothe Veterans Affairs Medical Center and Ohio Health Doctors Hospital. He received his medical degree from Ohio University Heritage College of Osteopathic Medicine in Athens. He's been practicing for more than 20 years. So he's going to talk to us tonight about his journey into psychiatry and the difference between mental illness and a brain disorder, how powerful language can be in the field of psychiatry, and he's also going to talk about depression and anxiety. So welcome, Dr. Resch. Thank you for being with us.
Well, thank you, Bethany, and thank you everyone else for being here. It's a real pleasure. Again, Bethany did a great job of introducing myself, so I'll just skip over this, but I'm really excited to be here today and talking to you about a mixture of things. And when Bethany reached out to me and asked me what I wanted to speak on, she mentioned a couple different things, which we'll get to. I also think it's really important to try to keep this somewhat interactive. So feel free to, ask me any questions at any time. I actually welcome that and appreciate that. I've actually built in 8 different spots where I'll pose some questions to the audience that I hope you'll be willing to participate in. Just pretty standard questions, but good ones for the interaction. But like I said, Bethany kind of mentioned a couple different topics that we'd be talking about today, and I was like, well, that's a mix of things, but a good mix. And I got to thinking, what am I going to call this talk and entitle it? And I ended up with psychiatric, and we'll explain that symbol here in a little bit, potpourri, which is a mix of things that's really good and nice to have around. So that's kind of what we're doing here. We're doing a mix of, I think, about 5 questions that were submitted by CURESZ Club members, as well as I threw in about 4 different things that I think is very important when I talk to people like yourselves or students or medical students or residents. I always try to impress upon them certain things that we'll be going over tonight. And she mentioned a couple of them. Somebody asked about my path into medicine and psychiatry, and I know some of you are going into the mental health field, so certainly have a slide or 2 on that. I also want to kind of touch upon how wide and diverse this field is. With 2 people on the call are on different types of paths for the same field, discuss some of the basics as it applies to psychiatry and mental health. Great questions submitted by a CURESZ member, all the ones in blue. Difference between mental illness, brain disorder, language, talk about academic anxiety, and somebody asked about imposter syndrome, which you hear more and more about. Review some recommendations on, kind of what to do with depression or anxiety when you're having trouble accessing care. Finally, looking at some other options you can do before you get to care. And then finally, in my opinion, discuss some of the ways that, psychiatry has a really bright future. I'm excited to say, and I'll share a little bit of that with you if time allows. So nothing to disclose. I think it's important to, disclose anything if there are any conflicts, financial or otherwise, but I work primarily as a psychiatrist 100% of the time. That's the only thing I compensated for. Sometimes we may or may not talk about medications, but I'll have to, be generic about that, non-specific. And any treatment recommendations discussed tonight are meant to be very general and not specific to any one person or case. So with that, I'll open up by just kind of briefly discussing my path to medicine, my path to psychiatry, which is always unique. As a psychiatrist, we're somewhat told to not focus on ourselves and not disclose too much in treatment, but it's good in this case to do so. I'll start off with my first interactive question. My original dream job was not a psychiatrist. So any guesses on what that might be from the audience? I'm not sure anybody will get it. Nobody has before.
Engineering.
Engineering, not quite. As a Ohio boy, I liked trucks. I liked It was somebody who had a chat thing. I wanted to be a garbage truck driver, but garbage truck person, but more specifically the one that hung off the back and, kind of rode around and got the trash. We had a real friendly guy, and I was like, that's a good job and looks like fun. You always get your holidays off. And I kind of kept that dream up until I started visiting my mother in her hospital. She was a nurse for 50 years, and my father, as you can see, was a high school science teacher. But we'd go to my mom's to visit for lunch, and we'd end up in the cafeteria, and I just couldn't believe what an amazing, intriguing place it was, with all the different people coming and going, the different uniforms, everything about it was just fascinating to me, and it's still fascinating to me when I go into any hospital. I just like the setting. The other thing, as a young, impressionable kid, there was some conveyor belt that you'd put your food tray on, and I just loved watching that kind of go to wherever, and it just kind of stuck with me. And I also think, my parents were wonderful to me, and I think due to their influence, I had a bit of a inclination naturally and through their modeling to go into a service field like this. And then, of course, with my dad's science background, I really liked the sciences too. So kind of gravitated towards both. And it was kind of natural when I did go to college, which was a higher university for undergrad. I started literally day one as a pre-med zoology major, which is just another term for essentially biology. And I never wavered from that. Some of my friends and things would switch, but I always stuck to that. And fortunately, I got into medical school, still was not thinking psychiatry. I was thinking either family medicine, because all the different things they can do, or orthopedic surgeon, because I love sports. I was close on the former. It was probably my second choice had I not gone into psychiatry. And I was way off on the latter, orthopedics. It was just not my cup of tea. The whole surgery thing was not for me. But at OU, they would put you in with various clinical encounters early on in your medical school career. And mine happened to be randomly assigned to the state psychiatric hospital in Athens, also known as Appalachian Behavioral Health. And immediately, something just struck a chord with me, resonated in me, and I found my new career path. Everything shifted at that point on. I just loved everything about it. I loved the patient interaction, the difference you can make, the medications, the therapy, the whole nine. Everything was good. So I found my kind of new career path and never wavered from that. And currently, I believe I have an ideal job. It's kind of a blend of seeing patients half the time and then teaching fellow future psychiatrists that are called residents the other half of the time. So it's a nice mix for me, and I really enjoy what I do. Today I saw patients and taught, so it was a nice mix. So, I still remain very passionate about psychiatry and being a psychiatrist, even after 20 years of practice. Still going strong, still very excited by the field. I think in any job, no matter what your chosen profession or calling is, it's really important to think about, hey, why am I doing that? Why am I doing this? To have that power and sense of purpose. And when I think about it, I think I help people with mental health concerns lead better lives. And it doesn't get much better than that. And that's a simple way to put it. And yes, I don't oftentimes cure people like in the oncology world when they talk about cures, but I care for people and treat them and their symptoms to the greatest extent possible using what we call evidence-based practice or evidence-based medicine. So that's kind of my calling, my purpose. When people ask me what I do, I'll say a psychiatrist. I usually get one of two responses. One will be like, oh, I've got to watch what I say around you, which is completely not the case. That might have been, 60, 70 years ago when all we did was psychoanalyze people, but we rarely do that anymore. The other one I get is, oh, that must be tough just hearing, the things you hear all day long. And it's really not. It really isn't tough at all. And I'm going to show you some slides amongst all of the field on why that isn't true and why it's a good profession, why people like to go into psychiatry through these surveys that come out every year, it makes it pretty clear. The other thing that supports the fact that this career is a good one is the fact that it continues to grow. And I've been part of this whole timeline here where at one time it was kind of stagnant, not a lot of people going into it. But then around 2011, things changed and people started to go into the field more. They opened up more programs, probably about 100 more programs now exist in the last 10 years. The number of applicants are record high, and we actually have to turn away people, unfortunately, which I'll talk about, from the field because there aren't enough residency training spots for them. The recent match just happened 2 Fridays ago, and a lot of people had to choose other fields other than psychiatry because there just wasn't enough room for them to be trained. And that's an important point that I'll impress upon you. Some people don't think, there are enough psychiatrists, and it's not because there isn't the supply. It's the fact that there's not enough training spots. And this was evidenced in the recent State of the Union address. President Biden talked about the need for more workforce and psychiatric care providers, as did our governor of Ohio, Mike DeWine, in his State of the State address, also made note to say, hey, we need more people to go into the field. And that starts for psychiatrists with opening more residency spots, which are federally funded, federally supplemented for the hospital. So just a couple slides on, when people say, oh, that must be hard. It can be hard, but it can also be very gratifying and very satisfying to work with the people we end up working with. And, people talk a lot about burnout in medicine, especially in recent years with the pandemic. As you can see here, psychiatry ranks towards the bottom in terms of burnout, the bottom kind of tier, which I think is good, and it's not as hard as a lot of people might think. Secondly, this is another way to kind of pose it. Would you choose the same specialty? Would I choose psychiatry again? Without a doubt, I would. But as you can see here, 86% of psychiatrists would choose psychiatry all over again, meaning only 14% would not. And that ranks pretty high up there, as you can see, compared with a lot of other specialties. So it's above average. This is an article I've loved since I read it back in 2019, just basically saying that we're lucky to be in the position we are to help people recover from mental health concerns. And I read this, every 6 months or so, just to remind myself of things. And without going into great detail, there's a line in it: psychiatry is filled with extraordinary moments of healing, honesty, insight, and human connection. And I can't agree with that more, 100% of the time. That's why we choose this field. That's why we stay in this field. This is why we love this field, for all those reasons and more. The other thing I like I've always kind of been in team activities, team sports. I like the fact that psychiatric world is, made up of teams. And we've got, people on the call here today that are going to be joining those teams in the future. And you'd be surprised how much of a team it is. Granted, this is going to change from place to place, area to area, but you're still going to be working with a team, which I really enjoy. I get a lot out of it. I've learned a ton from them. I hope they've learned from me and my special training and disciplines. And the buzzwords now are, hey, every mental health team or organization is going to be very interdisciplinary or very multidisciplinary. These are big words you hear anymore. It's not a single entity or a single person running the show, nor would I want that, or it would be advisable. You want as many different backgrounds and people and degrees to kind of be working for a shared goal. And each person on that team truly plays an important role with a unique perspective. Once again, it's going to be different depending on where you're at, what kind of diagnosis you may or may not have, the location, the setting, stage of treatment, etc. But I like the team aspect. Here's just a couple examples. I didn't even put them on here. Like, unfortunately, I don't have the LMHC on here, but I think most people have seen the left column here. the different types of trainings and backgrounds. You see more and more nurse practitioners, physician assistants, advanced practice nurses to fill that demand that we say has really not ever been met or currently being met. Different types of nursing, case management, art therapists will work with, occupational therapists, speech therapists, recreational therapists, peer support workers, which are great. They are typically people that have had much success in recovery, and they help others with what they've learned and what they've experienced. Great team member there. Marriage and family therapists, LPCCs, and other types of counseling. Pharmacists, they have clinical pharmacists that work right with us to choose the right medications, manage the medications, etc. Licensed chemical dependency counselors, and again, I've left some off here, but as you can see here, it's a wide, diverse field, which makes it a very good one to be in. So back to the basics of psychiatry and mental health, which will kind of roll into other things. Back to my title slide of this sign that you sometimes see representing really all of psychology, psychiatry. Where does this sign come from? It's a Greek letter for psi, which is the beginning part of psyche, which also means of the mind or soul. So the discipline of psychology and psychiatry is really the study of the mind, which will lead us into our next topic. And sometimes when we were on paper charts, people would just literally draw that sign and put eval, and that would mean a psychiatric evaluation needs to take place. And it was so ubiquitous and common, less so now with an electronic medical record, but still people utilize it. And the CURESZ staff is that medical staff, oftentimes added to reflect the medical training that psychiatrists go through, which is different than the more social science training that a psychologist would go through. So I'm going to segue here into some other areas with the language here, because I know this is a captive audience, all of you kind of doing what you do and studying what you do. And no big surprise that our words have tremendous power in various ways, but certainly in mental health. And some of these words are, to me, working in the field like I have, they're like nails on a chalkboard when I hear them. They're just hard to hear, but you hear them, unfortunately, too much. And these are obvious words that we should never use. They should not come out of our mouths. We should not be using them. And I even hate to read them, so I'll just let you read them. But these are words you avoid. These are stigmatizing words. These perpetuate stigma from the old days. And I guess the one I will say is people, another one, they'll say, if I say I'm a psychiatrist, they said, oh, you're a shrink, or I'll have patients call me a shrink, and I try to modify that, reframe it, but that's very derogatory. That's not what we do. So those are the obvious ones. These are the less obvious ones that are still very important and worthwhile talking. I recommend never identifying a person by their illness first. So it's not a schizophrenic patient, it's a patient with schizophrenia, or a bipolar patient, it's a patient with bipolar disorder, and down the list. Alcoholic should not be used. That's a person with alcohol use disorder. And you see the different things. Neurotic, you're not your illness. You're much more than that. So we call that a person-centered language or person-centered model of care, where, hey, they're a person first and foremost, no matter what diagnosis or diagnoses they have. So always preface it by saying it's a person or people with schizophrenia or fill in the blank. That's really important. Not as obvious as that other slide, but still very important. This is a much better way to do it, and I hope we can all kind of modify that moving forward. It just takes practice. This is another big one for me. I don't like the word committed suicide. That's the nails on the chalkboard for me. And why is that? What are some guesses out there that why that isn't good?
Well, committed sounds a little bit like a crime to me.
Yeah, is that Bethany?
Yeah.
Yeah, sorry, I can't see everybody, but yeah, that's exactly right. It does harken back to the days where it was considered a crime or a mortal sin. Think of other ways you use that term: committed adultery, committed murder, committed a sin. It takes away the fact that they were living with a mental health condition that caused that, not anything else. So it's just bad language, bad terminology. Similarly, you hear other kind of not so great things like, hey, that was a successful suicide or unsuccessful attempt, in highlighting that that's a tragic outcome. There's nothing successful or unsuccessful about it. So using that, say died of suicide rather than committed suicide. Say suicide death rather than successful attempt, and on and on. So, the other thing I don't like is suicidal gesture. We shouldn't use that term. That's a gray area, slippery slope. Describe, the behavior, but not that they were crying for help or a suicidal gesture. That's not good for stigma. So this is kind of more subtle, I guess, less obvious. Try not to use the words that perpetuate the public stigma, the institutional stigma of, hey, they're suffering from X, Y, or Z, a victim afflicted. Just say they have a history of it, very factual. They're being treated for it, or they live with schizophrenia. That's much better than saying, anything else. Don't use terminology that explains everyday things that we all do at various times and trivializes it and saying, that's just my OCD. That's my ADHD. That's just too flippant. And it's stigmatizing and not good for the field. And don't use mental health terms or diagnoses as adjectives. And unfortunately, you hear this a lot in the news. They'll talk about schizophrenic policy or bipolar stock market. No, there's no need for that. And it's stigmatizing and not good. This is the last one that I threw in because I think it's an interesting one. I think another gray area. But you'll hear this a lot of different fields. People will call patients clients, depending on the treatment setting. And this was adopted kind of 10, 15 years ago when they tried to kind of demedicalize the field and say, hey, it's more of a transaction. It's less hierarchical, that you're supposed to follow the instructions and be more collaborative with your treatment provider. In real world practice, it's kind of used interchangeably or even simultaneously. But what does this audience think? Do you prefer the term client or the term patient? Any thoughts on that?
I think there's good aspects to both. I think when you use the term patient, it kind of humanizes the situation a little bit more versus client, like you said, it is just more transactional. But yeah, that's mine. But I also think on the flip side, if you use the word patient, it medicalizes it in a way. Whereas client, I don't know. I'm sorry, not articulating this very well, but I think client just makes it more just cut to the chase, straightforward, has less of like a medical disorder type of undertone to it, I guess.
Yeah, I can appreciate that. I appreciate you sharing it. Again, I can go either way on this. I guess given the fact that I went through medical training and stuff, and I do take this caring for patients so seriously, I guess if I had to choose, I would prefer patient, but I'm not against client either. But I kind of lean that direction, in my own opinion. So bottom line on the language, and I don't mean to get on a soapbox and be preachy here. I'm just here to say language is really, really important, no matter what the situation is when it comes to mental health and stigma. How we talk about it and the people that are living with mental health conditions is often just plain wrong. And again, I've been in it 20 years, and I'm convinced that a large part of the problem is just people don't know what they're saying or what it means or how it comes across or how it impacts people that are living with mental health conditions. Because I know people, and they're well-informed and experienced care providers that still use inappropriate terminology or insensitive language, like the commit suicide language. But when I bring it to their attention, tactfully and professionally and as an aside, not in public, in a respectful way, they totally get it. My parents, a good example of that. They were always using wrong terminology, but now they're using the right terminology and they'll catch themselves sometimes. So just things to think about. So we're a little over halfway, doing pretty good on time, but any questions on that? Because it's a really important topic. Okay. Another question submitted by a CURESZ Club member was about academic anxiety and imposter syndrome kind of related together, and another good topic. I'll start off by somewhat normalizing it and saying, hey, you want some degree of tension, anxiety to help you perform at a better level. It's not always a bad thing. And as you can see here on this famous graph from 1908, if you didn't have any anxiety or tension, you probably wouldn't go to class, you wouldn't study hard, and you'd probably fail. But if you have a healthy degree of anxiety, stress, tension, it actually encourages you and fuels you to study and, hey, I got to do my homework every single day. And it actually improves your attention. But it's an upside down thing. If that's too much, you start to go down the other side and you start to get more anxious, distressed, fatigue, exhaustion. You see how it breaks down the other way. So the key is to keep it in this healthy, optimal range to help you perform at your best. So when it becomes excessive is when we run into academic anxiety problems. And typically this is 6 weeks or more. And sometimes people will even throw the term clinical in there to denote that it's clinical enough to where they're going to have to get treatment for it or seek out attention from a professional to help them with. So it's generic. Anxiety is too generic. So you want to break it down into 4 components. You can have mostly worry, emotionality, task-generated interference, and study skills deficits. And trying to identify which one you have the most of is really important because, like we said, with deciding whether it's more medical or more mental health or more brain versus mental health, it's going to affect your treatment and what you do. So worrying about it is pretty straightforward. It's just, random thoughts of, hey, I'm going to fail. I'm not good enough. I'm, worried about doing poorly. And it's just not helpful. It's all negative stuff. And you get kind of cognitive distortion, as we call it. So you can reverse that through positive mental imagery that athletes do all the time. Academics can do that. But also kind of catching your negative thinking and your self-defeating thoughts and distortions, catching them, correcting them, and modifying them is the basis of what we do in cognitive behavioral therapy. That's exactly what they do. So that is kind of the treatment for academic anxiety from a worry standpoint. And don't underestimate the power you can have to do that on your own. There's a lot of stuff online that you can work through. This is a classic book we recommend all the time to patients with depression and anxiety to kind of correct that distorted thinking. There's plenty of evidence out there to support self-hypnosis, mindfulness-based stress reduction techniques, and meditation. And again, I have no affiliations with these, but a lot of people do get benefit from apps like Calm or Muse, which actually does a version of neurofeedback to help you stay in that kind of zone of healthy brainwave activity to kind of help you keep on that peak of that curve that we just looked about. Emotionality, this is kind of more like where you just have biological, physiological symptoms of your heart's racing, you're sweating, you feel tense, stiff. The most effective strategies to combat that is to do what we call progressive muscle relaxation. You can do it anywhere you are, class, home, car, wherever, It's just like 4 or 5 steps, and it's very effective. The other thing is what we call, therapeutic breathing. This is called the 4 square technique of breathing. Breathe in 4 seconds, hold it for 4 seconds, breathe out 4 seconds, hold again, and that's a square. And you just mentally do that until you're calmer. That emotionality is lessened. So these are really high yield techniques. Task-generated interference is where you keep doing something that interferes with your grades, and looking at the clock, just doing things that don't work for you, and that leads to problems. You're not going to get as much out of the other things, treatments, as this. This one really, you got to work on your study skills, and a lot of schools have these guides or these counselors that help you identify the thing that's interfering and try to correct it. Same goes for study skills deficit. Something's not right, and again, that's going to need probably some went the wrong way. Some study skills assessment and counseling to kind of help correct. So the next one they asked about was imposter syndrome, and this is something you hear more and more about over the probably last 5 to 10 years, where you self-doubt your abilities and feel like you're a fraud or an imposter and don't belong there. A lot of self-doubt. Interestingly, this affects more people that are high achieving who find it difficult to accept their success for whatever reason. This is especially prominent in medicine. I don't care what level you are, pre-med, med, attending, chairman, it runs rampant through medicine. The worst thing you can say to a medical student is, how'd you get into medical school? Because it's just not good. Michelle Obama is a very good example of somebody very successful, but she's very open about her own imposter syndrome. And she has several YouTube videos I would direct you to, and she describes it really well. And again, you just don't think you deserve the accolades. And it's not considered a psychiatric diagnosis, more of a kind of a social thing that we're dealing with, and a phenomenon that's equal amongst men and women, and pretty commonly leads to depression and anxiety, which is where it becomes more psychiatric in nature. So this is kind of a person getting a Employee of the Month award, and actually he doesn't even appreciate it because of this imposter syndrome. So I got to watch my time, but you really have to start asking some tough questions like, why am I feeling this way? And digging into that, leaning into it, whether it be on your own or with a counselor or with your therapist. And these are some real world recommendations that I would recommend that you look at. I'm not going to read them all for the time, but the ones that I liked are on the second one. Really be careful to compare yourself. There's really no good that comes out of that. Also, the big one I think for this generation is use social media, mildly or minimally or moderately, not excessively, because that's where you get into this comparing things. Those are probably my 2 most recommended ones on this slide here. So this is a good question with limited access, another CURESZ member question. Review some recommendations on how to deal with depression and anxiety when there's access to care challenges.
Also, Dr.
And
you got about 10 minutes to go, okay?
Okay, thanks. I'll try. So basically, this is a good question. I'll make a couple recommendations to try to get yourself, timely, local, accessible, safe mental health treatment. First, tell yourself, hey, like most medical conditions, depression, anxiety tend to be episodic. They're not constant. So tell yourself, through mantras, this is only temporary. I'm going to get better. This too shall pass. I've gotten better however many other times I have. And you also have to say, hey, depression and anxiety, they're some of our most treatable psychiatric conditions. And we fortunately live in a time where we just don't have one modality like therapy. We've got therapy. We've got tons of medications. We've got neuromodulation techniques, other therapies that we combine. So it's a good time to get treatment. Keep reminding yourself that, kind of like that positive imagery. And the good news is care has never been more accessible. The pandemic has made telemedicine very common. I never did telemedicine until the pandemic. Now it's like you don't even think about it. Most colleges and universities, since some of you are there, are more aware of mental health conditions, and they have formal mental health treatment protocols and pathways that you can work through and with. I'll also remind you that not everybody needs to see a psychiatrist or a psychologist. The first line truly is your primary care doctor for straight depression or anxiety. And they're more than capable of prescribing those effectively, safely, competently. And that's usually where it starts. Only the more complicated cases tend to filter through the psychologist, the psychiatrist realm. There's a new phenomenon called behavioral health integration, where they're putting psychiatrists with me, like me, with primary care docs for like an hour a week, and we just talk about cases, and I give them recommendations, and it works really good. That's a more efficient way. So I do that with 3 primary care offices locally, and that's more and more common. At Ohio Health, the system I'm at, we're in 75 of 140 primary care offices, and we're planning to implement that more. So that's a thing about access that you might not even know existed unless you hear about it. And then if you're in crisis, any major sized ER is going to have a mental health professional there 24/7, 365 to help manage through crises and triage to the best level of care for that person. A lot of people think it's like a binary thing, inpatient, outpatient. Well, there's like 3 steps in between as well. There's intensive outpatient, partial hospitalization program, aftercare services. There's plenty of things that a lot of people just aren't aware of to access. Also, another question, look at some alternative recommendations for mental well-being while awaiting to get into a provider for diagnosis or treatment. And here again, there's a lot of things you can do while you're waiting for that to happen. And don't underestimate them. These are high-yield endeavors. And there's probably nothing earth-shattering, but it's all evidence-based. I've seen it work hundreds of, not thousands of times. And again, we don't have time to kind of go through it, but the pillars of health are nutrition, exercise, sleep. If I had to choose one, it's going to be sleep to really help you. And better sleep, better you. I was sensitized to this, but I saw a commercial the other day. It's true. A good day starts with a good night. And sleep's important for a variety of reasons. It improves concentration and productivity, so your school performance, your work performance. It is linked with depression and anxiety. It's linked to inflammation, which can cause other flare-ups with schizophrenia or other psychotic spectrum conditions. Sleep improves your immune function. That's extremely important to fight infections of all kinds. And this is the foremost authority on sleep. And their treatment guidelines recommend a form of cognitive behavioral therapy for insomnia called CBTI, not medications. And again, this is a psychiatrist saying medications are not first line. So the CBTI is a therapy that you can walk through and learn how to do it. Again, I might send these slides out to Bethany, but it's a great thing. Here's another thing, thanks to technology. This is a free domain app created by a coalition of Stanford and the VA Department of Defense. It's a CBTI app that you can get on your phone and work through CBTI on your own with very good effect size and results. So if you have sleep problems, I would recommend this, or you know somebody that has sleep problems, this would be a good thing to try. So again, we pretty much know sleep hygiene. Again, you can get a lot out of this. In my experience, the big 3 are limiting your caffeine, keeping to a routine, even on weekends, and watching the devices at night or putting on the screen filter for blue light blockers or the glasses or what have you. I wouldn't be a good psychiatrist if I didn't warn you against using drugs or alcohol during these tough times. They just add fuel to the fire. And also how important staying social is and connected to your loved ones, your family, your friends. That's therapeutic. Don't fight the urge to isolate yourself. That's not going to help you. And again, if you needed any reinforcement of the things I just said, that same survey, Medscape, that does for psychiatrists, look what they do to maintain their happiness and mental health. Everything that we just mentioned, socialization, exercise and sleep, eating healthy, from the people that are in the field. So we're almost going to make time here. Again, I went into this field with optimism and trying to help out as many people as I can. Fortunately, I've never been more optimistic and excited about the future of this field for the following reasons. We're slowly but steadily chipping away that stigma, which was, has been there a while. People are more willing to enter into treatment, like everybody on this call probably. That's great. People going into the field, all different disciplines, to make that interdisciplinary team strong. The amazing effects, honestly, of grassroots organizations like NAMI, Mental Health America, the Trevor Project, and now, of course, the CURESZ Foundation. That is awesome to see. Advances in neuroscience, I think somebody's in that degree here. Neuroimaging has helped us. Biomarkers have helped us. New medications have helped us, whether it be for tardive dyskinesia or other ailments in mental health. So the future is bright. Again, this is somewhat my opinion, but you're still going to see a ton of telemedicine, telehealth, as we call it. Psychiatry is kind of tailor-made for that. Behavioral health integration, where they're going to combine psychiatrists with primary care to impact more people and reach more people. Progression of personalized medicine through, blood tests, brain waves, things of that nature, more novel medications, even psychedelics like ketamine, psilocybin, maybe not exactly those, but utilizing them to come out with new medications that target the same thing. Brain stimulation techniques that, again, work on the hardware to make areas of the brain function better and correct some of the dysregulation. Continue to evolve neurofeedback, biofeedback, and many more things that probably aren't even out. But the bottom line is, I want to leave you that the future is bright for all of mental health. So we really have, I think, gone through this psychiatric potpourri. Again, I think I have one of the best jobs in the world. Never have regretted a single day in my 20-plus year career. There's countless of people that choose to be in it for the same reasons. More is better, so I'm glad that all of you are in some way or form, kind of part of this field, whether it be going into it or peer support or just advocacy and education. That's what it's about. There are differences between, like we said, the mental health spectrum and the brain disease spectrum, but they're not absolute. Some don't fit so nicely. Language. Just watch your language for the reasons we already went over. Academic anxiety and imposter syndrome, since somebody brought it up, super common, but quite manageable if you kind of work through it in the ways we talked about. The 3 pillars of health, I really strongly believe in those, apply to both mental and physical health and well-being. And access, at the end here, access to timely, safe, effective mental health care has really never been better than it has now. It's still not perfect. We still have a ways to go. I'm not trying to dismiss any of that, but it's better than it's ever been, and it's probably going to only get better post-pandemic for the reasons we talked about. So again, the future for mental health and people with mental health concerns, in my opinion, is super bright. So with that, I just made time, but I'd love to take any questions if there are any.